We'll start with one important topic today. We'll start with the nerve injuries in the upper limb part. Okay. The most important aspect of upper limb will be nerve injuries. All your clinical cases that have been ever asked is on nerve injuries. Even this exam, they asked only radial nerve. Okay. So the most important, the first topic that you will concentrate when you're studying upper limb is nerve injuries. Before we understand, you have to understand the anatomy of brachial plexus. Anatomy of brachial plexus. Brachial plexus, as the name says, is a plexus of nerves that supplies the upper limb. It is formed by the ventral rami of C5, C6, C7, C8, and T1. So these are the ventral rami, also called anterior rami. Ventral rami or anterior rami of C5 to T1. Now, what do you mean by this? Now, imagine this is a spinal cord, guys. Okay. So from this part is the anterior part. This part is the posterior part. Anterior part is also called ventral part. Posterior part is also called dorsal part, right? And they give the roots, a dorsal root and a ventral root. So this will be ventral root and that will be the dorsal root. And then they form the spinal nerve. They form the spinal nerve. Okay, don't write notes. Whatever I tell you, that much is enough. This is just to create the concepts. These spinal nerves then divide into a anterior rami and a posterior rami. These posterior rami, they go to back muscles. They only supply the back muscles. They are going to the trunk, back of the neck, like that. It is the anterior rami, also called as ventral rami. So anything which is anterior, when I start crawling, just imagine this is the anterior part. When I start crawling, guys, it becomes the ventral part. So anterior rami or ventral rami of spinal segment C5 to T1, this forms the brachial plexus. So brachial plexus is formed by spinal rami. Okay, the spinal nerve C5 to T1. Which rami? Anterior rami or the ventral rami? It is the ventral rami of C5 to T1 that forms the brachial plexus. C5 and C6 unite and form the upper trunk. 7 single, 7 single, 7 single forms middle trunk. 7 is single. C8 and T1, they form the lower trunk. So please remember, there is no lateral trunk, there is no medial trunk. The naming of the trunk is important to understand. Upper trunk, middle trunk, and lower trunk. And 7 is single. So if you can just make the thing, it becomes easier till now. So just remember the diagram. C5 to T1, C5, C6, C7, C8, and T1. What are these? These are spinal segments. C5 to T1. What are constituting the roots of brachial plexus? The ventral rami or the anterior rami of spinal segments C5 to T1. Each of these roots then divide into an anterior division and a posterior division, anterior division and a posterior division, anterior division and a posterior division. So imagine the dotted lines as posterior divisions and the solid lines as anterior divisions. So each trunk is dividing into anterior and posterior division. A previous MCI question that was asked is total number of divisions in brachial plexus. Answer was 6, 3 anterior, 3 posterior. But I don't expect such questions in future. So, the question previously asked was total number of divisions in brachial plexus, 6 divisions, 3 anterior, 3 posterior. Each trunk divides into an anterior and a posterior division. All these posterior divisions unite and forms the posterior cord. All the posterior divisions unite and form the posterior cord. The anterior divisions of the upper trunk as well as the middle trunk unite and form a lateral cord. And the anterior division of lower trunk continues as a medial cord. Medial cord. So once again, there is a naming of the cords is different, naming of the trunks is different. In the cords, we have a lateral cord, posterior cord, and a medial cord. In the trunks, we have an upper trunk, middle trunk, and a lower trunk. So please differentiate these things. If you understand the names, it is easy. If you confuse with the names, you think there is an upper cord, there is no upper cord. There is no lower cord. Once you understand the names properly, brachial plexus is an easy topic to do. Once again, brachial plexus is divided into roots, trunks, divisions, cords, and then we get branches. The roots of the brachial plexus or the ventral rami or anterior rami of C5 to T1 spinal segments. The C5, C6 unite and form the upper trunk. The C7, 7 single, 7 single, 7 single middle trunk. C8 and T1 forms lower trunk. Each trunk divides into anterior and posterior divisions. All posterior divisions unite and form the posterior cord. The anterior divisions of upper and the middle trunk, they form the lateral cord of brachial plexus. And the anterior division of lower trunk continues as a medial cord of brachial plexus. Then, talking about the branches, are you okay till here, guys? Are you fine till here? Simple only till here? Okay. Yes. So now the naming, just look at the image here. So they may give you this image because it's a more of image based things. So I want you to concentrate on the images also. What I showed you was a line diagram, but in the exam, they may show you this thing in the neck and the supraclavicular region, and you have to identify this brachial plexus and the branches also. So what I want you to understand is this is the C5, okay? You can see this is the C5 till T1, okay? Sometimes you may get contribution from C4, you call it prefix type. And sometimes you may get contribution from T2, that is called as postfix type. But mainly it is formed from C5 to T1. And you can see that the C5 and the C6 uniting and forming the upper trunk of brachial plexus. So this is the upper trunk. 7 single is continuing as a middle trunk. C8 and T1, you can see C8 and T1 uniting and forming the lower trunk of brachial plexus. So first you need to understand this. And till these roots, right, these roots, the trunks, they are supraclavicular. They are above the clavicle. The divisions are actually just behind the clavicles. They are just posterior to clavicle. Roots and trunks are present in the neck, posterior triangle of the neck. They are above the clavicle. Divisions are present just posterior to the clavicle. And you can see the divisions, the anterior divisions and the posterior divisions, anterior division, posterior divisions, right? So you can see the divisions of all these things. And the anterior divisions of upper trunk and the middle trunk are uniting and forming, this is your lateral cord. So this thick bundle formed by the anterior divisions of the upper trunk and the middle trunk are uniting and forming the lateral cord. All these posterior divisions you can see are uniting and forming, this is the posterior cord of brachial plexus. So you can see the posterior is formed by all the posterior. And then you also have the anterior division of the lower trunk, which is continuing as a medial cord. So tomorrow they show this image, they will label it A, B, C, and they're asking you what is this. You should be able to tell which is lateral cord, which is posterior cord, which is the medial cord of brachial plexus. And these are infraclavicular, they are below the clavicle. So divisions are behind the clavicle, and below that is infraclavicular in the axilla, right? So they come down in the axilla. So the cords and the branches. The next thing, after doing that, we have to understand the branches now. The branches come from different cords. The lateral cord gives some branches, the medial cord gives some branches, and the posterior cord, this is the posterior cord, and also your medial cord, they give different branches. There are some branches coming from the roots of the brachial plexus. There are some branches coming from the trunk of brachial plexus. I'll simplify in a line diagram, but just want you to get familiar to it. So first thing, identify the roots, identify the trunks, the divisions, and the cords from the image. Identify the roots, trunks, cords, and the branches, right, from the image. The important branches, at least we have to learn. Let us try to understand the diagram a bit more. Just let me just simplify it. C5, C6, C7, C8, T1. So we know that this is how the trunks are formed. From the upper trunk of brachial plexus, we get two branches. We do not get branches from the middle trunk or the lower trunk. You do not have branches from the middle trunk or lower trunk. We get branches only from the upper trunk of brachial plexus. From the upper trunk, we get two branches. One is suprascapular nerve and another is nerve to subclavius. Nerve to subclavius. These are from the upper trunk of brachial plexus. There are some branches coming from the roots also. We'll write the notes. Okay, I'll give you the notes accordingly. But just for now, understand, I'm just trying to explain you the image now. Okay, it's more of image thing. So I'm just trying to help you understand the image. Before that, I'm drawing this line diagram so that you have some thought process in you. So upper trunk of brachial plexus gives two branches. What are they? Suprascapular nerve and a nerve to subclavius. Talking of the C5 root, C5 gives rise to dorsal scapular nerve, dorsal scapular nerve. And then C5, C6 and C7, these three things unite and form the long thoracic nerve, long thoracic nerve. So when you are seeing the image, I want you to appreciate these branches. There will be two branches coming from the roots, one only from C5, another from C5, C6 and C7. Whereas two branches come from the upper trunk of brachial plexus. There is suprascapular nerve and the nerve to subclavius. We'll understand what these branches are and all in detail. I'll make you write the notes and all. But for now, the image, let us try to identify them on the images. So let's see them on the images. So if you can see here, this is the C5 root, right? This is C5. So can you see from the C5, C6 and C7 uniting and coming, this nerve which is having the roots of C5, C6 and C7, this is your long thoracic nerve. So you'll be able to see this thin nerve coming from the roots C5, C6 and C7. This is your long thoracic nerve. And only from C5, only from C5 you get another nerve. This is your dorsal scapular nerve. Important is to identify long thoracic nerve. For the image, it is important that you identify or pick up long thoracic nerve from the image. So C5, from the C5 you get dorsal scapular nerve. From C5, C6 and C7 you get the long thoracic nerve. The next thing was the trunk of brachial plexus. So this is upper trunk, this is middle trunk and this is lower trunk. There are no branches from middle trunk and lower trunk. There are no branches. Only upper trunk gives rise to branches. So you are seeing two branches coming from the upper trunk. This one is a suprascapular nerve, right? And this one is a nerve to subclavius. Because it is coming from the upper trunk and upper trunk is formed by C5 and C6. It also has the same root values of C5 and C6. That is suprascapular nerve and nerve to subclavius. So I hope tomorrow if they mention it as A, B, C and D, you will identify them. A is dorsal scapular nerve. B is long thoracic nerve. They come from the roots of brachial plexus. From the upper trunk, we get suprascapular nerve and the nerve to subclavius. Nerve to subclavius. There are no branches from divisions. Okay, if you can see, there are no branches from the divisions. Divisions do not give any branches. But you will have branches from the cords of brachial plexus. The different cords, they give branches. Let me just make some mnemonics for that. So branches, just write this down, branches from cords of brachial plexus. Branches from cords of brachial plexus. The first one are branches from the lateral cord. It's a simple mnemonic LML. L stands for lateral pectoral nerve, musculocutaneous nerve, and lateral root of median nerve. Lateral root of median nerve. So this is the first part of the notes that you are going to write, lateral root of median nerve. So branches from the roots were dorsal scapular nerve and long thoracic nerve. We'll come back to in details about it. Okay, I just wanted to get the image first. I'm not discussing anything. I'm discussing the image only, guys. Okay, we'll write down in detail later. So branches from the lateral cord are lateral pectoral nerve, musculotenious nerve, and lateral root of median nerve. What is the mnemonic to learn that? LML, LML, lateral pectoral nerve, musculocutaneous nerve, and lateral root of median nerve. So let's see these images now here. So concentrate on the images here. Please look at the image here. So they may point out what is A, what is this B, what is this C, like that. Okay. So first we are trying to understand what are the branches of the lateral cord. Please remember the median nerve has two roots. A lateral root coming from the lateral cord and a medial root coming from the medial cord, together forming the median nerve. So when you see that kind of arrangement where the two roots coming, a lateral root and a medial root uniting and forming a nerve, so this nerve would be median nerve, this would be lateral root of median nerve, this would be the medial root of median nerve. So you are identifying the first branch out of LML. You have identified the first branch. The next thing, the main branch that is coming from the lateral cord is the musculocutaneous nerve. Okay, the musculocutaneous nerve. And this small branch which supplies the pectoral muscles is the lateral pectoral nerve. Musculocutaneous nerve has to go and supply the arm. The lateral pectoral nerve supplies the pectoral muscles. We'll discuss about each nerve in detail. The image is what I'm trying to get you familiar with. Complex image, so just trying to spend some time on that. On the lateral cord, look at the median nerve origin, then decide it is a lateral root of median nerve. The main branch coming from the lateral cord would be the musculocutaneous nerve, and also it gives rise to the lateral pectoral nerve. The next thing. Then coming to the branches of the posterior cord of brachial plexus, branches of the posterior cord. Talking about the branches of the posterior cord of brachial plexus, we have something called as ultra. So you have to remember this mnemonic, ultra. Okay, what does ultra stand for? Upper subscapular nerve, lower subscapular nerve, thoraco-dorsal nerve. Thoraco-dorsal nerve is also called as nerve to latissimus dorsi. Radial nerve, and axillary nerve. So upper subscapular, lower subscapular, thoraco-dorsal nerve, also called as nerve to latissimus dorsi, radial nerve, as well as axillary nerve. So ultra, some people learn it as lunar also. So whichever is comfortable for you. Lower subscapular, upper subscapular, right? These are mnemonics we are using. Nerve to latissimus dorsi, axillary nerve, as well as radial nerve. So either of the mnemonic you can use, lunar or ultra, to get to these names. Okay, so branches of the posterior cord of brachial plexus. So once you see them, let's try to identify them. Okay, let's try to identify them. The major branch of the posterior cord is radial nerve. So the first identify the posterior cord. So you know this is the posterior cord. All the posterior divisions are uniting and forming the posterior cord. So once you have understood the posterior cord, then we are seeing from this posterior cord, the branches are coming. The major or the largest branch, remember it like this. The largest branch of the posterior cord of brachial plexus is the radial nerve. So this is how you have to identify the radial nerve, the largest branch of the posterior cord. Then this another terminal branch is the axillary nerve, and the branches that come here, these are your ultra. You have a upper subscapular, you have a lower subscapular, and in between you also have the thoraco-dorsal nerve or the nerve to latissimus dorsi. Upper subscapular, lower subscapular. Upper will be obviously a little higher and lower will be downwards, right? So this is upper subscapular, this is lower subscapular, and in between you have the thoraco-dorsal nerve or nerve to latissimus dorsi. So important out of all of them, guys, is these branches. They will point, rather than asking these small branches, they will want you to know which is musculocutaneous nerve in the image, which is radial nerve, which is axillary nerve. These terminal branches you should be able to identify. So largest branch of the posterior cord of brachial plexus is your radial nerve. Radial nerve. Okay, I'll give you the mnemonics later. Okay, the small mnemonics. You can easily learn it as, Marmu, Marmu, right? So if you learn like this also, you'll be able to learn these branches: musculocutaneous nerve, then axillary nerve, then radial nerve, then median nerve, then ulnar nerve. So these terminal branches, they will ask you, and that mnemonic of Marmu, Marmu will help you identify which nerve is what. But still try to concentrate on what I'm trying to tell you. Branches of posterior cord. Ultra is the mnemonic. Upper subscapular, lower subscapular, thoracodorsal nerve, axillary nerve, radial nerve. So largest branch is radial nerve. You also get a small branch there, axillary nerve, and the upper subscapular, lower subscapular, and thoracodorsal. I hope you can manage that. And important, which is radial nerve. Please don't confuse radial nerve and median nerve. Median nerve will have two roots coming and joining. Radial nerve is the largest branch of posterior cord. So that is another thing in the image that you have to concentrate on. The last part are branches of the medial cord of brachial plexus. Branches of the medial cord of brachial plexus. Now, talking about branches of the medial cord of brachial plexus, in the medial cord of brachial plexus, we use a mnemonic M for U. M for U. That means we have four M's: M, 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 and U. Medial cutaneous nerve of arm. Medial cutaneous nerve of arm. Medial cutaneous nerve of forearm. Arm, forearm. Brachii, arm means brachii, and this is antebrachii, right? So medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial root of median nerve, medial root of median nerve, medial pectoral nerve, medial pectoral nerve, and lastly is the ulnar nerve. So M for U, four M's and a U are branches of medial cord of brachial plexus. What are they? Medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial root of median nerve, medial pectoral nerve, and ulnar nerve. Let me show you the images and again I'll come back to you. Okay, we'll write all of this in detail thoroughly, right from roots till all. Just trying to get you familiar to the image only, guys. So M for U. Medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial root of median nerve, medial pectoral nerve, and ulnar nerve. So let us look at the image. We are talking about branches of the medial cord. So this is the medial cord. I told you the branches are lateral cord, right? The posterior cord and a medial cord. In the medial cord, if you see here, you can see this branch is the medial pectoral nerve. Then medial brachial cutaneous nerve. Brachial means cutaneous nerve of arm. Antebrachial means medial cutaneous nerve of forearm. So medial pectoral nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm. Then comes the major things, the medial root of median nerve. So you can see here, this is the medial root of median nerve coming. And last, this is the ulnar nerve, which is a major branch coming from the medial cord of the brachial plexus. So these are the branches of the medial cord of brachial plexus. Try to understand what we are trying to do here. We are trying to identify the image of the brachial plexus. We have not done anything else. The only thing we are concentrating is to understand the image. Tomorrow you see an image, ABCD is written. You should be able to catch it. Guys, 100 images have come in, okay? And this is one of the important images that are asked in USMLE exams. If somebody has attempted any questions in USMLE and all these are labeled as A, B, C, D. And they're asking you to identify which nerve is what. So our intention here is to understand that question. First thing, branches from the roots, dorsal scapular nerve, long thoracic nerve. Branches from the trunk, only upper trunk gives rise to branches. They are suprascapular nerve and nerve 2 subclavius. Branches from the lateral cord. Branches from the lateral cord, LML. Lateral pectoral nerve, musculocutaneous nerve, lateral root of median nerve. Branches from the posterior cord, ultra. Upper subscapular, lower subscapular, thoracodorsal nerve, radial nerve. The largest is radial nerve and the axillary nerve. So you can remember MARMU, marmu. So that will help you. So musculocutaneous nerve, axillary nerve, radial nerve, median nerve, and ulnar nerve. Branches of the medial cord of brachial plexus, M for you. Medial pectoral nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial root of median nerve, and the ulnar nerve. Will you manage? Will you manage that labeling? Can you manage this labeling, guys? Which is axillary, which is radial? Can you manage all of you, right? I hope you will do that right. Okay, that images you have to be careful with. Now let's come to the concepts now. Okay, let's come to the concepts. I'll tell you. So just understand the roots and the trunks. They are supraclavicular. They are in the neck region. They are in the posterior triangle of the neck. They are in the supraclavicular region. The divisions, they just lie behind the clavicle, whereas the cords as well as the branches, they lie in the axilla. So one exam, okay, they asked a question like this: which of the following is infraclavicular branch of brachial plexus? Which of the following is infraclavicular branch of brachial plexus? Options were dorsal scapular nerve, suprascapular nerve, long thoracic nerve, axillary nerve. What do you think is the answer? Correct answer? Of you are right, that is the axillary nerve. So that is the reason I was telling you to learn, right, which is supraclavicular and which is infraclavicular. That's good. The next thing now let's come to some proper notes. First one, branches from roots. Branches from roots of brachial plexus, right? The first part is the dorsal scapular nerve. Dorsal scapular nerve. And this dorsal scapular nerve goes on the dorsum and supplies the muscles on the dorsal aspect, okay, of the near the scapula. Let me show you the image. I think I have kept one image. I hope if you once you see that image on the dorsal side of the scapula. Now look at this image here. This is the scapula, right? You're looking at the dorsal side, the posterior side of the scapula. Am I audible, guys? Okay. So this is on the dorsal side. And on the dorsal side, we have these muscles. What are these muscles? If you can see, this is the levator scapula, right? This is elevating of the scapula. This muscle here are the rhomboidus muscles, rhomboidus major and the minor muscles that are present here. So again, image is important, guys. So they may show which is supplied by dorsal scapular nerve. So just have the thought what I'm trying to tell you. As the name says, dorsal side of the scapula, attached to the medial border, all these muscles which are attached to the medial border of the scapula, these are supplied by dorsal scapular nerve. These are supplied by dorsal scapular nerve. So levator scapulae, rhomboidus minor, rhomboidus major, all of these are supplied by the nerve dorsal scapular nerve, which is coming from the roots of the brachial plexus. So the first thing I want you to understand is from the roots we have dorsal scapular nerve. And what does it supply? Dorsal scapular nerve, what does it supply? It supplies the levator scapulae muscle. It supplies the rhomboidus muscles, the rhomboidus major and minor, rhomboidus major and minor. All these muscles attached to the medial border on the dorsal side of the scapula are supplied by the dorsal scapular nerve. So that is one thing, the first part of the brachial plexus. The next thing, the another important route and the one which is very frequently tested for your clinical scenarios is long thoracic nerve, also called as nerve to serratus anterior. Nerve to serratus anterior. Again, very important, very important nerve of your brachial plexus, guys. Okay, there are some nerves which are very high yield clinical scenarios, radial nerve, long thoracic nerve. You should do them thoroughly. Now, some students were telling that even this question was asked. Let me just, explain you what all things can come. So long thoracic nerve, or also called as nerve to serratus anterior, as the name suggests, is coming from serratus, is going and supplying the serratus anterior. It is coming from the roots of brachial plexus. The dorsal scapular nerve we knew is coming only from C5. The long thoracic nerve was coming from C5, C6, and C7 roots. So it is coming from C5, C6, and C7 roots, and it supplies the serratus anterior muscle. Long thoracic nerve is damaged in radical mastectomy. Very important point. Radical mastectomy, or radical mastectomy means you remove the breast as well as axillary lymph nodes. So they can say during axillary lymph node dissection. Axillary lymph node dissection. So long thoracic nerve is damaged in radical mastectomy as well as in cases of axillary lymph node dissection. During radical mastectomy, we do axillary lymph node dissection. So any of this question is given up, a breast cancer patient undergoes surgery and she has axillary lymph node dissection. After that, she's having paralysis of which of the muscles? Okay, you have to be able to understand what is being asked. So radical mastectomy, which is a breast cancer surgery that we do, where you remove the pectoral muscles, where you remove the axillary lymph nodes, right? So the axillary lymph node dissection, it is a common indication where you may have injury to the long thoracic nerve, also called as nerve to serratus anterior. Now, there are a few things that you need to understand with serratus anterior. Let me show you the image before we go into the discussion. So if you see the muscle serratus anterior, let me show you the muscle serratus anterior to make you understand better. If you see this muscle serratus anterior, if you see, it is originating from the upper ribs and inserting on the medial border of the scapula. So you can see that it is going and inserting on the medial border of scapula. So when it contracts, it pulls the scapula forward. It helps you to have this punching movements. So when it pulls the scapula forward, when it contracts, the scapula will move forward. It helps in punching movements. So because it helps in punching movements, serratus anterior has been called as boxer's muscle. So I want you to understand this thing, serratus anterior. Don't learn origin, insertion, and other things. Whatever is necessary, we'll explain you. Okay, whatever we feel is important, we'll tell you. Just concentrate on the clinical aspects of long thoracic nerve or nerve to serratus anterior. Serratus anterior is also called as boxer's muscle. It is also called boxer's muscle because it helps in punching movements. Okay, for punching or pushing movements. Pushing movements. And it is also helping in overhead abduction. Overhead abduction, that is abduction more than 90 degrees. Overhead abduction or abduction more than 90 degrees. Serratus anterior, because it is helping in punching, pushing movements, right? Not pulling. It does not help in pulling movements. It is helping in punching, pushing movements, as well as overhead abduction. Overhead abduction is more than 90 degrees of abduction. Please understand, okay, if you look at abduction, this is an important part to understand, guys. The abduction is divided into three parts. The abduction, okay, if you're moving, abduction. The initial 15 degrees of abduction, this is caused by supraspinatus. The initiation of abduction, if they say initiation of abduction. Okay, so if you're looking at abduction, the initiation of abduction, the beginning of abduction is caused by supraspinatus. Then 15 to 90 degrees of abduction, this is by the deltoid. And more than 90 degrees of abduction, that is overhead abduction, this is caused by two muscles. It can be due to trapezius or it can be due to serratus anterior. Serratus anterior. This, this wordings I want you to be careful with. Instead of saying overhead abduction, they will say that the patient is having difficulty in combing the hair. So for combing, I need overhead abduction. Or they will say the patient is having difficulty lifting something from a height. For lifting something from a height also, he needs overhead abduction. So it is important for you to understand what is happening here, right? So it is important to understand that overhead abduction can be said that difficulty in combing the hair, difficulty lifting something from a height. So all of this should make you understand that there is weakness of overhead abduction. And another thing is one question was asked, which movement is not done by serratus anterior? Options were pulling, punching, pushing, or overhead abduction. Which one will your answer? Yes, very good. It is A. You do not do pulling movements. So pulling requires posterior movements. Okay, this is just helping in making it come forward. So you do not have serratus anterior doing pulling movements. It is used for punching, pushing, or overhead abduction, not pulling. Okay, so you need to understand that thing. And imagine what would happen if there is damage to long thoracic nerve. If the long thoracic nerve that is damaged during axillary lymph node dissection or radical mastectomy, if this serratus anterior is lost, so the serratus anterior will be attaching to the medial border of scapula and pulling the scapula forward. But if there is damage to serratus anterior, the medial border of the scapula will become more prominent. You cannot pull the scapula forward. Instead, it goes backward and the medial border of the scapula becomes prominent. This is also the image some students say. Okay, it's based on recall. I have to, still get the final answers. But one of the students, okay, some of the group of students were telling that this was also the image that was given, and they showed winging of scapula. And this winging of scapula is damage to which nerve? The long thoracic nerve, or the nerve to serratus anterior. So a clinical case will be given here. It's a very important point for clinical case scenarios. A patient is a female who had a breast lump, underwent surgery. So they will not say radical mastectomy, axillary lymph node dissection. You should understand, obviously, in breast cancer surgeries, we do axillary lymph node dissection. And she developed these features. And this is what? Winging of scapula, damage to long thoracic nerve. So the next point I want you to learn in long thoracic nerve or nerve to serratus anterior is winging of scapula. This year's exam question. Okay, probably this was the exam question that was there. This type of one image based question was there. Yeah, that is what I'm saying. It's okay that you have to understand winging of scapula was asked as an image based questions. Okay, next thing, long thoracic nerve. Next thing. So these are the two things from the roots that we have discussed. Two things from the roots of the brachial plexus. Next part is branches from the upper trunk. Branches of upper trunk of brachial plexus. There are no branches from the lower trunk, middle trunk. There are no branches from the divisions. Okay, we have branches only from the upper trunk. And there are two branches we learned, suprascapular nerve. And this suprascapular nerve is responsible for supplying two muscles. It supplies supraspinatus and infraspinatus. Right, both supraspinatus and infraspinatus are supplied by suprascapular nerve. Nothing much clinical here. They may just ask initiation of abduction. Initiation of abduction is by supraspinatus. The 0 to 15 degrees of abduction is by supraspinatus and it is supplied by suprascapular nerve. The next is the nerve to subclavius. So these are the two muscles that are, these are the two nerves that are coming from the upper trunk of brachial plexus, suprascapular nerve and nerve to subclavius. Just a small muscle under the clavicle, no clinical importance there. So we'll just learn the names and leave it there. Suprascapular nerve and nerve to subclavius are the two branches coming from the upper trunk. The suprascapular nerve supplies supraspinatus and infraspinatus, and the nerve to subclavius, as the name says, supplies the subclavius muscle. So are we okay? Branches from the roots. What were the branches from the roots? Branches from the roots were dorsal scapular nerve as well as the long thoracic nerve. Branches from the roots of brachial plexus, dorsal scapular nerve from C5 root, long thoracic nerve from C5, C6 and C7. Branches of the upper trunk of brachial plexus, suprascapular nerve, and nerve to subclavius. The next thing we come to are branches of the lateral cord of brachial plexus. The cord, there are no branches from divisions, then we are going to branches of lateral cord of brachial plexus, LML. In that we have lateral pectoral nerve. As the name says, it supplies the pectoral muscles, the pectoralis major. It supplies pectoralis major. So pectoral, it's easy to understand, nothing much about it. Musculocutaneous nerve, we learned that this was the main branch. We'll learn in detail. And we'll also have a lateral root of median nerve. Lateral root of median nerve. And lateral root of median nerve was going and joining with the medial root of median nerve, right? So, and that was, we'll study with median nerve separately. So we have only one nerve to do, that is the musculocutaneous nerve. That's it. In lateral cord, we have what? LML. What is the mnemonic we used? LML. LML Vespas we had, right? Old times. LML. Lateral pectoral nerve, musculocutaneous nerve, and lateral root of median nerve. Lateral root of median nerve. The lateral pectoral nerve supplies pectoralis major. Then we have musculocutaneous nerve and the lateral root of median nerve. Let's try to understand the musculocutaneous nerve, the main branch of lateral cord. Musculocutaneous. Again, there's a lot of clinical relevance here. I wanted to concentrate on this. The first nerve that is important is the long thoracic nerve, which is already asked. Now the second nerve, this is your musculocutaneous nerve, that is important. Okay. I'll just show you the images again. Okay. I didn't understand. Image based one slide. I'll just show you. Okay. Just concentrate. Let's understand this thing first. Musculocutaneous nerve. It is a branch of which cord? Lateral cord of brachial plexus. Now look at here. This nerve has two parts, muscular part and a cutaneous part. Musculocutaneous nerve supplies muscles of anterior compartment of arm. Anterior compartment. Anterior compartment of arm. And what are they? You learn it by the mnemonic BBC. Okay, BBC newspapers, BBC, I mean the TV channels and all very famous, right? BBC you can learn. So musculocutaneous nerve supplies all the muscles of the anterior compartment of the arm. They are biceps, brachii, brachialis, and coracobrachialis. Coracobrachialis. Then there is also a cutaneous branch. Cutaneous branch. The cutaneous branch supplies or gives rise to or becomes the lateral cutaneous nerve of forearm. So just understand this. The musculocutaneous nerve has two parts, a muscular part and a cutaneous part. The muscular part supplies muscles of the anterior compartment of the arm. So in the arm, we have this biceps muscle, brachialis, right? So in the muscles of anterior compartment of arm only. Biceps brachii, coracobrachialis, as well as brachialis. These are supplied by musculocutaneous nerve. And what is the cutaneous part? It becomes the lateral cutaneous nerve of forearm. Lateral cutaneous of forearm is a branch of musculocutaneous nerve. Musculocutaneous nerve. Now, this muscle brachialis that we are discussing here among the BBC, this is a hybrid muscle. Okay, it is basically a hybrid muscle. Has a dual nerve supply. It has a medial part and a lateral part. The medial part is supplied by musculocutaneous nerve and the lateral part is supplied by radial nerve actually. So if they say what is the nerve supply of brachialis, brachialis has dual nerve supply. It has a medial part supplied by musculocutaneous nerve and a lateral part supplied by radial nerve. So musculocutaneous nerve is also supplying it, radial nerve is also supplying brachialis. So that is one thing I want you to understand. Next. Then let me explain you what kind of clinical scenario will come and how you should be ready for this. So you have simple two parts, muscular part, cutaneous part, muscles of anterior compartment of arm and lateral cutaneous nerve of forearm. The muscles of anterior compartment of arm, BBC, biceps, brachialis, coracobrachialis. And in that we understood the brachialis. Now concentrate here. Now concentrate on this thing that biceps brachii, the muscle in the anterior aspect of the arm. This is helping in flexion of the elbow. Okay, biceps and brachialis, they are strong flexors of the elbow, right? Flexion. We all know that. Triceps is extension of elbow. Biceps is flexion of elbow. And biceps is also responsible for supination. It is also the chief supinator of the arm. Chief supinator. Okay, so this is supination. Beggars supinate, kings pronate, beggars supinate. You should be able to differentiate. Kings pronate, beggars supinate. So biceps is the chief supinator also. Concentrate carefully. Biceps brachii. What is the nerve supply? Musculocutaneous nerve. What are the actions of biceps brachii? Flexion of the elbow, and is also the chief supinator of the forearm. So chief supinator of the forearm is what? Biceps brachii. With this much of information, let's see how a clinical case on musculocutaneous nerve will come. I saw a question like this. A 25-year-old male met with road traffic accident and has swelling around the shoulder. On examination, the patient has extended elbow and weakness of supination. Which other finding can be expected in this patient? Now look at the question here. It's a clinical question. Road traffic accidents are common in young males, right? So a 25-year-old male met with a road traffic accident is having some injury around the shoulder, and he's having inability to supinate and also has his elbow which is extended. Which other finding can be expected in this patient? Loss of extension at wrist, loss of extension, not extension, loss of flexion at wrist, loss of sensation on lateral aspect of arm, or loss of sensation on lateral aspect of forearm. What do you think will be the correct answer here? What do you think is the correct answer? Very good, Mansi, Daya, Pavitra, Harshad, right? That's good. I'm happy you guys are answering it right. Avni, right? That's right. Pradyam, Pavitra. So please understand, first looking at the question, we understand that the patient has extended elbow, means the patient is having problem in flexion, right? So all the flexors of the elbow, that is biceps and brachialis, they are supplied by musculocutaneous nerve. And he's also saying there is weakness of supination, and we know that biceps brachii is an important supinator. So here there is damage to biceps or the nerve supplying biceps, that is the musculocutaneous nerve is damaged. By looking at the question, we should interpret that musculocutaneous nerve is damaged. So he's saying what other finding can be there. So we know that musculocutaneous nerve supplies the muscles of the anterior aspect of arm and becomes lateral cutaneous nerve of forearm. So it is not the arm, it is loss of sensation. It's cutaneous innervation. Loss of sensation on lateral aspect of forearm. So this should be the correct answer. Please understand, musculocutaneous has two parts. A muscular part supplying muscles of anterior aspect of arm, and a cutaneous part supplying the lateral cutaneous nerve of forearm. Lateral cutaneous nerve of forearm. So please remember, lateral cutaneous nerve of forearm. Lateral cutaneous nerve of forearm is a branch of musculocutaneous nerve. Musculocutaneous nerve. But if I say medial cutaneous nerve of forearm, if I say there is loss of sensation on medial aspect of the forearm, where do you think it is coming from? Where is medial cutaneous nerve of forearm coming from? Very good, Sneha. Very good, Avni. It is coming from what? Medial cord of brachial plexus. Okay, it is a damage to medial cord of brachial plexus. So we know that the medial cord gives rise to M for U. Medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial root of median nerve, right? So M for U. So the medial cutaneous nerve of arm, medial cutaneous nerve of forearm. So that medial cutaneous nerve of forearm is a branch of medial cord of brachial plexus. Lateral cutaneous nerve of forearm is a branch of musculocutaneous nerve. Musculocutaneous nerve. So you're okay with the branches of the roots of brachial plexus? Dorsal scapular nerve supplying the muscles on the dorsal aspect of the scapula, that is your levator scapulae, rhomboidus major and rhomboidus minor. All the images that I'm showing you will be given to you in the PDF format in the groups and all, need not worry about it. Then long thoracic nerve, right? Serratus anterior, winging of scapula. Okay, image based question, important to understand. Next, suprascapular nerve coming from the upper trunk and the nerve to subclavius. Branches of the lateral cord, lateral pectoral nerve supplying pectoral muscles, musculotenious nerve supplying that muscles of the anterior aspect of the arm, and the skin over the lateral aspect of forearm. Skin over the lateral aspect of forearm. So that is all about the lateral cord of brachial plexus. Fine. Okay, we'll just do one important branch. Okay, the posterior cord also, if you can patiently do it. So we'll just finish off the posterior cord also. Fine. So now we'll move to posterior cord of the brachial plexus. Posterior cord of brachial plexus. And I hope you can manage the image of brachial plexus. Okay, a little complicated, but I hope you can put that marmu. Okay, please remember that marmu and keep that in mind. Musculocutaneous nerve, axillary nerve, radial nerve, median nerve, ulnar nerve, in that order. Marmu, M-A-R-M-U. Okay, just and also think over what all I told you. Okay, look for median nerve joining by two roots and all. Okay, important image of brachial plexus is an important question. Next, branches of the posterior cord of brachial plexus, posterior cord. And I told you the mnemonic, ultra. So in this, these two are very, very important for your exam, clinical based questions. Other are just for fact based things. I'll just do that and then come to the main clinical scenarios. So posterior cord of brachial plexus gives rise to upper subscapular nerve that supplies the upper part of the subscapularis muscle, lower subscapular nerve that supplies the lower part of the subscapula. The lower subscapular nerve also supplies teres major. Okay, the lower subscapular nerve also supplies teres major, not teres minor. Teres minor is axillary nerve. Teres major is lower subscapular nerve. This is a fact based. Just listen it and have an idea and leave it. Thoraco dorsal nerve. This has been asked in your previous MCI exams. They used to ask thoraco dorsal nerve is also called as. Try to understand the word. Dorsum of the thorax, and if you know latissimus, when you go to gym and all, you do lats, right? So they are on the lats. Okay, Hrithik Roshan has that V-shaped appearance of the latissimus muscles. So thoraco dorsal, so basically lats, so a thoracic part of on the dorsum of the thoracic region, right? So latissimus dorsi. So thoraco dorsal nerve is also called as nerve to latissimus dorsi. I'll tell you how the question was asked. They said, which of the following is supplied by thoracodorsal nerve? Rhomboidus, serratus anterior, latissimus dorsi, like that. Please remember, rhomboidus is supplied by dorsal scapular nerve. Serratus anterior, long thoracic nerve. Nerve to latissimus dorsi is thoracodorsal nerve. Okay, they just try to make you understand the other names. Okay, fact-based questions. Okay, easy exam times. That was the question that was asked. Now we have to do two important nerves, radial nerve as well as axillary nerve. Very, very high yield for your exam, especially with the changed pattern. We'll do axillary nerve, which is a very small nerve, and then move on to radial nerve before we take a break. So let's understand. So we did what? Ultra, upper subscapular, lower subscapular, thoracodorsal nerve, radial nerve, axillary nerve. Upper subscapular, subscapular muscle, lower subscapular, subscapular muscle, as well as teres major. Then thoracodorsal nerve also called as nerve to latissimus dorsi, the climber's muscle. Okay, latissimus dorsi helps in climbing. Okay, climber's muscle is latissimus dorsi. Boxer's muscle is serratus anterior. Boxer's muscle is what? Serratus anterior. The next one, okay, axillary nerve and radial nerve. I'll start with axillary nerve. Axillary nerve is very simple. Axillary nerve, it originates from the posterior cord. So first thing, you know, it is part of posterior cord, all this ultra posterior cord of brachial plexus. It supplies only two muscles, okay, only two muscles in the body. One is deltoid and one is your teres minor. Only two muscles, deltoid and teres minor. And you need to know few things about deltoid to be able to answer the questions of axillary nerve. Axillary nerve supplies deltoid. Deltoid is responsible mainly for abduction of shoulder. Abduction of shoulder, especially the main part of abduction. About 15 to 90 degrees of abduction is by deltoid. And you know, deltoid is a multipinnate muscle. It has fibers anteriorly, superiorly, and posteriorly. And the anterior fibers are helping in flexion. Okay, it has multipinnate fibers. Okay, the anterior fibers. So it is like this. Okay, so anterior fibers help in flexion of the shoulder. Superior fibers helps in abduction of shoulder. Posterior fibers help in external rotation and the extension of the shoulder. Teres minor is also an external rotator of the shoulder. Okay, it helps in external rotation of the shoulder. So if you have damage to axillary nerve, please expect loss of abduction and loss of external rotation of shoulder or weakness of external rotation of shoulder, because the teres minor and the posterior fibers of deltoid, they are external rotators also. And also remember, deltoid is responsible for the rounded contour of the shoulder. So they'll say a flattening of shoulder is due to, okay, so they ask shrugging of shoulder this time in your exam, in this exam, conducted exam, and they may ask you rounded contour of the shoulder also. Please remember, the rounded contour of the shoulder, the appearance of the broad shoulders, is because of the deltoid muscle. So if there is loss of rounded contour of shoulder, think of deltoid paralysis, think of axillary nerve damage. So rounded contour of the shoulder, the broad shoulders that we have, is because of the deltoid. And another thing with axillary nerve, it not just supplies the muscles, it also supplies skin over deltoid. It also supplies the skin over deltoid. And this region over the skin over the deltoid is called as regimental badge area. Regimental badge area. So damage to axillary nerve can lead to loss of sensations over the deltoid. And this is called as regimental badge sign or regimental badge sign. Damage to axillary nerve. When you are giving intramuscular injections and all, you may have damage to that axillary nerve. Okay, so once again, only two things to understand. Two muscles, deltoid and teres minor. Very simple. Teres major is different. Teres minor is different. Teres major is supplied by lower subscapular nerve. Teres minor is supplied by axillary nerve. Please differentiate deltoid and teres minor. Deltoid and teres minor are supplied by what? Axillary nerve. Skin over deltoid as well as the muscle deltoid are supplied by axillary nerve. Just a course of axillary nerve I want you to learn. Few things in the axillary nerve. So after this is the regimental badge area, guys. Okay, this area is called as the regimental badge area. So in military, when they have these regimental badges, okay, it will be on that area near the deltoid. So on the deltoid region, so they have these badges. This is called regimental badge. So this loss of sensation on the deltoid is called as regimental badge sign. Damage to axillary nerve. Please remember, axillary nerve, it passes through quadrangular space of the shoulder. I'll teach you spaces of shoulder as well as the muscles later. Quadrangular space. Okay. Along with posterior circumflex humeral arteries. So in the course, these two things are important. It passes through quadrangular space along with posterior circumflex humeral vessels, as well as it winds around surgical neck of humerus, winds around surgical neck of humerus. So the nerve that is damaged in fracture surgical neck of humerus is what? Axillary nerve. And also remember, it is the most common nerve damaged in shoulder dislocation. It is the most common nerve damaged in shoulder dislocation, especially anterior dislocation of shoulder, which is the most common dislocation of shoulder, damages the axillary nerve. Most common dislocation of shoulder is anterior dislocation, and it commonly damages the axillary nerve. So this is in the course that you have to understand. So on the shoulder, back of the shoulder, we have quadrangular space, triangular space, like that. We'll teach you when I teach the muscles and other things. So it passes through the quadrangular space, goes and winds around the surgical neck of humerus. And any fracture of surgical neck of humerus, any damage to surgical neck of humerus, as well as any shoulder dislocation. Whenever shoulder is dislocated, it will be dislocated here only, right, in the axilla. So it's not a difficult thing. Don't write radial nerve and other things. Shoulder dislocation, obviously, axillary nerve damage. So shoulder dislocation, fracture surgical neck, and faulty intramuscular injections in deltoid can damage axillary nerve. There will be loss of rounded contour of the shoulder. There will be loss of abduction of shoulder, and there will also loss of sensation over the deltoid, called as regimental badge sign. So these are important things. Again, clinically important: surgical neck humerus fractures, shoulder dislocation can be given, right? Again, these are important. Clinical scenario will be telling you the patient loss of deltoid. Instead of saying that deltoid is paralyzed, they will say the patient has loss of abduction, loss of rounded contour of shoulder, loss of sensation on the skin over lower aspect of the deltoid, right? And they may also say loss of external rotation of the shoulder, So because of the loss of teres minor, loss of external rotation of the shoulder will also be there. So this all should make you think whenever there is loss of abduction of shoulder, loss of rounded contour of shoulder, right? Loss of external rotation of shoulder. Think of damage to axillary nerve. The teres minor, which is also an important external rotator, is supplied by axillary nerve. Teres major, lower subscapular, teres minor, axillary nerve. Clear? So let me show you the deltoid muscle also, and then we'll talk about the other things. So this is how the deltoid is there, the bulk of the muscle of the shoulder. And this deltoid, will be inserted, if we'll discuss all of this. Okay. The deltoid muscle, which is coming on the shoulder like this, will come and insert onto the deltoid tuberosity of the humerus. Okay, here there'll be a tuberosity that is called as deltoid tuberosity of the humerus. And on the back of the shoulder, you have spaces like this. Okay, we'll discuss this in detail. For now, just for axillary nerve, remember this is quadrangular in space. This is quadrangular space. So these are triangular spaces, upper triangular space, lower triangular space. So the axillary nerve comes from posterior cord, passes through the quadrangular space, winds around the surgical neck of humerus. Any fracture here will damage the axillary nerve, or any mass protruding into the quadrangular space, or any injury in the quadrangular space, there may be what? Damage to axillary nerve. So axillary nerve passes through the quadrangular space and winds around the surgical neck of humerus. Next thing. Before I go ahead, I want you all to remember this diagram of the humerus. Okay, so very, very important diagram. Just let's draw this. So imagine this is the head of the humerus. This is the shaft. This is the medial epicondyle. This is the lateral epicondyle. This is the trochlea, and this is the capitula. Okay. At the surgical neck of humerus, we have axillary nerve. Axillary nerve is present at surgical neck. Between the tubercles, imagine this is greater tubercle and this is the lesser tubercle. Here will be anatomical neck. And below the tubercles will be surgical neck. So anatomical neck, surgical neck. So the nerve that is passing in the surgical neck of humerus is axillary nerve. The nerve that is passing in the spiral groove, this or in the shaft of the humerus is the radial nerve. Again, this year's question. Okay, in the shaft of the humerus or in the surgical groove, spiral groove, or the spiral groove, also called as the radial groove or radial groove. So fracture spiral groove, fracture radial groove, or fracture of shaft of humerus, lower shaft of humerus. Please think of radial nerve damage. Behind the medial epicondyle, you have the ulnar nerve. Okay, just behind the medial epicondyle. This tunnel that is formed behind the medial epicondyle, this tunnel is called cubital tunnel. Okay, near the cubital fossa. So nerve damaged in cubital tunnel or nerve damaged in fracture of medial epicondyle is ulnar nerve. Ulnar nerve passes behind the medial epicondyle, and under the behind the medial epicondyle there is a tunnel called as cubital tunnel. So carpal tunnel is median nerve, cubital tunnel is ulnar nerve. And another nerve that is, these are the condyles of the humerus, lower condyles of the humerus. And this nerve that passes from the supracondylar area of the humerus. So this is your anterior interosseous nerve, branch of median nerve, anterior interosseous nerve, which is a branch of median nerve. So this is in the supracondylar area. So I keep telling all my students all the time that this is an important aspect, important diagram, and this exam, they said radial nerve was there. Okay. So please be careful with all the images here, all the nerves that are here. Please draw this diagram and learn this properly. The nerve that is damaged at the surgical neck is axillary nerve. The nerve damaged at the fracture shaft or the lower shaft of the humerus is radial nerve. Spiral groove, radial groove, that is okay. Nobody will ask you radial groove, but remember spiral groove, the nerve that passes through spiral groove is radial nerve. Behind the medial epicondyle in the cubital tunnel is ulnar nerve. In the supracondylar region, or in supracondylar fractures, the nerve that is damaged is anterosseous nerve, which is a branch of median nerve. So if they give anterosseous nerve, go for anterosseous nerve. If they don't give anterosseous nerve in the option, they give median nerve, you can select a median nerve. So anterosseous nerve, which is a branch of median nerve, is damaged. This is an important diagram. So again, now when I'm teaching radial nerve, we have finished axillary nerve now. When we go to radial nerve, again, I'll talk about this fracture of spiral groove. Are you okay with axillary nerve, guys? Quadrangular space, surgical neck of humerus, right? Regimental badge area, loss of abduction, external rotation of the shoulder. Only two muscles, deltoid and teres minor by axillary nerve. Are we okay with axillary nerve? Can we go to the next one? All of you, right? Can we go to radial nerve now? Let's go to the next nerve, the important nerve, that is your radial nerve. Very important nerve, and there's a lot of clinical integration that you have to learn about it. Concentrate it carefully. Radial nerve. Radial nerve comes from posterior cord. It is the largest branch of the entire brachial plexus also. Okay, the main nerve in the upper limb. Okay, the radial nerve. So you need to learn in detail about radial nerve. So radial nerve is coming from the posterior cord of the brachial plexus. It is the largest branch of the posterior cord of the brachial plexus. We know ultra is R stands for radial nerve. Now, I want you to understand that after its origin, radial nerve passes through lower triangular space of the shoulder. Passes through lower triangular space. Then it goes through spiral groove, passes through spiral groove. I'm just talking about the course before I go in details about it. Spiral groove along with the profunda brachii artery. Profunda brachii artery. Also called as the deep brachii artery, profunda brachii or the deep brachii artery. Then at cubital fossa, just at cubital fossa, okay, just near the lateral epicondyle, it divides into superficial branch and deep branch. Superficial branch is sensory. supplies skin on dorsal aspect of lateral 3.5 digits. Now please understand. So the superficial branch supplies the dorsal side, okay, dorsal side of 3.5 digits, this side. So okay, the 3.5 digits are supplied by the radial nerve. The deep branch pierces supinator, supplies supinator, pierces supinator, and becomes what is called as posterior interosseous nerve. I need you to understand this, guys, okay? I need you to understand this. Posterior interosseous nerve is nothing but the branch of radial nerve. Posterior interosseous nerve is a branch of radial nerve. After it pierces supinator muscle, it is called as posterior interosseous nerve. This deep branch is purely motor. So it supplies all the muscles of the posterior aspect of the forearm. So purely motor. We'll discuss this once again. Try to understand this once again. Simple. 3-4 lines only. We'll try to understand the course. Radial nerve comes from the posterior cord of brachial plexus, passes through the lower triangular space of the shoulder, right? Along with that, it goes in the profunda, along with the profunda brachii artery, it goes through the spiral groove or radial groove of the humerus. Coming at the cubital fossa, near the cubital fossa, at the level of lateral epicondyle, it divides into two branches. A superficial branch supplying the skin over the dorsum of lateral 3.5 digits, and a deep branch which pierces supinator and becomes posterior interosseous nerve, which is purely a motor nerve, Now, let me tell you exactly what is happening. So imagine, very, very important to understand, guys, this diagram. Imagine this is the radial nerve. It is coming from the posterior cord. It is coming all the way at the cubital fossa near the lateral epicondyle. It is divided into two branches. One is a superficial branch, one is a deep branch. Superficial branch is completely sensory. It goes and supplies the hand, 3.5 digits of the hand. The deep is piercing supinator, and after piercing supinator, the same deep branch is called as posterior interosseous nerve. And this posterior interosseous nerve supplies all the extensors of the forearm, like the extensor digitorum, all the extensor muscles. Okay, just understand this thing. Now, with this much of understanding that what is, I just talked about the course. I did not talk about the branches coming in and what it supplies and all. So just the course. It comes from the posterior cord, goes in the spiral groove through the passing of from the lower triangular space. Let me show you the lower triangular space. This is the lower triangular space, guys. So if you see on the back of the shoulder, this is the upper triangular space. This is the lower triangular space. So the radial nerve comes, goes through the lower triangular space, and then goes on to the spiral groove or the radial groove of the humerus. So it passes through the lower triangular space, enters into the spiral groove, then at the lateral epicondyle divides into superficial and deep branches. I want you to understand that a radial nerve is the chief nerve supplying everything posterior in the upper limb. It supplies almost everything on the posterior aspect of upper limb. So course we understood. Now we are trying to understand what it supplies. So this word posterior you keep in mind, or this letter P you keep in mind in relation to radial nerve. Radial nerve supplies the posterior muscles of the arm. And what are the posterior muscles of the arm, guys? Triceps and anconeus. It also supplies posterior muscles of the forearm. Posterior muscles of forearm are mainly supplied by the posterior interosseous nerve, right? And that is all the extensor muscles, extensors of forearm. Okay, to name few: extensor digitorum, all extensor, guys. Extensor digitorum, extensor carpi ulnaris, extensor pollicis to the thumb, extensor indicis, index finger. Okay, so all the extensor pollicis, extensor indicis, extensor digitorum, supplying all the extensors muscles. Okay, abductor pollicis longus, everything that is there on the posterior side. Abductor pollicis longus, right? Everything that is there on the posterior side is basically supplied by radial nerve, and these posterior muscles of the forearm are basically supplied by the branch of the radial nerve, that is the posterior interosseous nerve. Not just the muscles on the posterior side of the upper limb, it also gives rise to everything posterior cutaneous supply. So it gives rise to posterior cutaneous nerve of arm. Posterior cutaneous nerve of arm. It gives rise to posterior cutaneous nerve of forearm also. Right? It gives rise to posterior cutaneous nerve of arm, posterior cutaneous nerve of forearm, and through the superficial branch, it also supplies the skin over dorsum of the or the posterior aspect of the hand also. So through superficial branch or the sensory branch, superficial branch supplies the dorsum of lateral 3.5 digits. Lateral 3.5 digits. So everything posterior, basically everything posterior, all the muscles, all the nervous cutaneous innervation on the posterior side. So posterior interosseous nerve is a branch of radial nerve, posterior cutaneous nerve of arm, posterior cutaneous nerve of forearm, dorsum of the posterior aspect of the 3.5 digits. Okay, so everything posterior is supplied by radial nerve. Are you okay with this? Are you okay with this here? Simple only till here? Okay. Fine, guys? Okay, fine. Now, with this much of understanding, let's come to the clinical aspects, or what is supposed to be, more understood with radial nerve. Now, I want you to understand that radial nerve, when it is coming, imagine it is coming like this, and then dividing into a superficial and a deep branch. Please concentrate carefully. This is the radial nerve coming from the posterior cord. When it is still in the axilla, it supplies the triceps muscle. So when the radial nerve is still in the axilla only, at the axilla only, it is supplying the triceps. And triceps, we'll know, is for elbow extension. Very important, guys. Clinical scenarios are based on the level of injury. So we are trying to understand the level of injuries here. So radial nerve supplies triceps when it is still in the axilla, and we all know triceps is responsible for elbow extension. Then passing through the spiral groove, then coming down, it supplies the extensor carpi radialis longus, and just below that, so you can write it as ECRL, extensor carpi radialis longus, as well as extensor carpi radialis brevis. So this ECRL and ECRB, extensor carpi radialis longus, extensor carpi radialis brevis, extensor carpi radialis longus, extensor carpi radialis brevis. These are supplied when it is just crossing the spiral groove, and these are responsible for wrist extension. These are responsible for wrist extension at the spiral groove, near spiral groove. Then after that, the posterior interosseous nerve, this is supplying extensor digitorum, and this extensor digitorum is responsible for finger extension. Just concentrate, guys. So just understand what is happening. The radial nerve is supplying triceps. It also supplies all extensors, no exception. All extensor muscles of the upper limb are supplied by radial nerve. But the level it is supplying is important to differentiate. Triceps is supplied when it is in the axilla. Just near the spiral groove, the extensor carpi radialis longus, extensor carpi radialis brevis, which are responsible for wrist extension, are supplied. Extensor digitorum, which is responsible for finger extension, is supplied when it is in the forearm. At the level of cubital fossa, just above the lateral epicondyle, they are dividing into a superficial branch and a deep branch. Superficial and a deep branch. The deep branch after piercing the supinata muscle is becoming the posterior nerve. So it is in the forearm. Okay, it's already gone in the supinata, piercing the supinata, then becoming posterior nerve. In the forearm, it is supplying this thing. And we know this superficial branch is supplying skin on dorsum of 3.5 digits. Dorsum of hand and dorsum 3.5 digits. Are you okay with this? Are you clear with this thing? Level, where it is supplying elbow extensors, where it is supplying wrist extensor, where it is supplying finger extension. Are you okay? Now let me tell you the why it is very, very important. Okay, the main clinical questions that are asked are on this diagram, guys. Okay, please be careful. If they say radial nerve is injured at the axilla, just concentrate. Radial nerve injury at axilla. Radial nerve injury at axilla can happen in case of crutch paralysis. Okay, when you are using crutches, when you're wearing crutches and passing, okay, when you wear crutch, okay, handicapped people, when they walk with crutches, so there will be compression over the radial nerve. Okay, so it can happen at the axilla, or in case of injuries over the shoulder, road traffic accidents like that. So when you have damage at the axilla, when the damage is at axilla, the triceps is not working, so there will be loss of extension of elbow. Triceps is not working. So when the injury is at axilla, even extensor carpi radialis longus, extensor carpi radialis brevis are not working. So there will be loss of wrist extension. There will be superficial also, and deep also will not be working because the damage is much higher above. So when superficial is not working, there is loss of sensations on dorsum of hand and dorsum of 3.5 digits. When deep is also not working, your loss of supination will be there because it is supplying supinata, piercing it, and also loss of finger extension will be there. Fingers also will not be extended. This will happen when the damage is in the axilla, as in crutch paralysis or in shoulder injuries and stuff. So there will be loss of extension of the elbow, loss of wrist extension. So unable to extend, they'll be having a flexed elbow. So the elbow will be flexed, the wrist will be in drop, wrist drop, and also there will be finger drop. The fingers also will not be extended, there will be finger. So flexion of the elbow will be there, there will be wrist drop, and the flexion of the fingers will be there. So this happens at the level of axilla. It's very, very important to understand. If I say the injury is at the spiral groove, which is a common indication of radial nerve injury, fracture spiral groove, what would happen is triceps would be functioning. Tricep, there will not be any loss of extension. Extension of elbow will be good if there is damage to spiral groove, if the damage is at spiral groove. Spiral groove injury can happen in Saturday night palsy. Remember, when I'm having a Saturday night, I'm having a drinking and alcoholic intoxication, I keep like this on the back of the chair and sleep off on a Saturday night drinking heavily. So obviously when I keep my hand like this, there'll be pressure over the spiral groove. It's a neuropraxia that develops. It's a conduction loss that develops because of compression that is developing over the radial nerve. Or in case of honeymoon palsy, there's a partner who's sleeping on the arm, okay, in honeymoon, right? They can be, just sleeping with their heads on the spiral groove of the partner. So fracture of spiral groove or fracture, or in Saturday night palsy, or in case of honeymoon palsy, same thing, honeymoon or Saturday night or fracture spiral groove. In all of these conditions, the damage is at the spiral groove. So triceps is escaping injury. So triceps will be working. So don't think that, okay, spiral groove fracture, radial nerve is damaged, loss of extension of elbow will happen. No, loss of extension will not happen at the elbow because triceps is already supplied when it is in the axilla. When the damage is at the spiral groove and when the damage is at the axilla, there is a difference. When the damage is in the axilla, there is loss of extension of elbow. When there is damage to the spiral groove, there is no loss of extension of the elbow. There is only wrist drop. There will be wrist drop. When there is loss of extension of wrist, there will be wrist drop because of damage to wrist extension, and also there will be damage to the finger. So there will be loss of wrist and the finger extension also. But if there is damage, at the elbow, okay, just imagine just near the lateral epicondyle, just at the just before the division, if it is dividing, if there is injury, fracture lateral epicondyle, fracture of lower part, okay, of the lateral epicondyles, like that. So you'll have only cutaneous loss as well as finger drop. Okay, there will be cutaneous loss and finger drop. But if there is damage to only posterior interosseous nerve, okay, maybe radial head, when you're having injury of the forearm, radial head of the radius, right, radius, head of radius, subluxation, or surgeries at the radial head, or fractures at the radial head, or forearm bone fractures. So when you're having injury of the posterior interosseous nerve, there will be no loss of sensation. Posterior interosseous nerve is purely motor nerve. The sensations are supplied by the superficial part only. So it will be purely motor loss and purely loss of extension of the fingers. So posterior interosseous nerve will lead to finger drop only, not wrist drop or not loss of any extension of the wrist or any extension of the elbow. They will not be affected. It will only be the finger extension that will be affected. So damage to posterior interosseous nerve will lead to finger drop. Once again, this is very, very important, guys. Which muscle is supplied at which level? This, if you understand, all clinical cases with radial nerve, you'll be able to manage. You know everything. Posterior is radial nerve. Posterior muscles of arm, posterior muscles of forearm, skin over the back of the hand, skin over the back of the forearm, arm, everything. Monopoly. There is a single nerve on the entire posterior aspect of upper limb. Monopoly of upper limb on the posterior aspect is by radial nerve. Radial nerve supplies everything posterior in the upper limb. Posterior muscles of the arm, the triceps anconeus, posterior muscles of the forearm, all the extensor muscles, right? Skin over the back of the arm, back of the forearm, posterior interosseous nerve, or skin over the dorsum of the back of the hand, as well as dorsal 3.5 digits. Everything is supplied by radial nerve. That is easy to understand. Monopoly. Level is something that I am trying to stress upon. In the axilla, it supplies triceps. At the spiral groove, it is supplying the extensor carpi radialis longus, extensor carpi radialis brevis, which are responsible for wrist extension. At the level of the forearm, the posterior interosseous nerve is supplying extensor digitorum, which is responsible for finger extension. So injury at the axilla will cause loss of extension of elbow, loss of extension of wrist, sensory loss on the dorsum of the hand, as well as loss of finger extension. Fracture spiral groove or injury to radial nerve at the spiral groove will spare elbow extension. It will not damage elbow extension. It will spare elbow extension. It will cause only wrist drop. So loss of wrist extension will lead to wrist drop, as well as sensory loss on the dorsum of the hand, as well as finger drop. But wrist extension will be affected, not elbow extension, if there is damage to spiral groove. The elbow extension is spared. Elbow extension is spared when there is damage to spiral groove, or Saturday night palsy or honeymoon palsy. When you have damage to posterior interosseous nerve, there will be loss of extensor digitorum muscles. The extensors of the fingers will be lost. You will have a finger drop. Posterior interosseous nerve injury leads to finger drop. I hope you are able to understand the level of injury. Are you okay with this, or do you want me to repeat this? Yes, if there's damage to spiral groove, everything below that is lost. Okay, so sensory loss is there, finger drop is there, wrist drop is there. Clear? But elbow extension is not lost. So don't think that, okay, triceps will be lost. No, triceps is spared. Triceps is not damaged if there is damage at the spiral groove. Are you all okay, guys? Anything else? Are you okay with this thing? This is an important diagram, and the level where it is supplying is also important. So triceps is spared when there is fracture of spiral groove or damage to radial nerve at the spiral groove. Finger drop is different, wrist drop is different. Finger drop occurs due to damage to posterior interosseous nerve. Wrist drop occurs due to damage to radial nerve. Are you all okay, guys? Is this crystal clear? If you are fine, okay, very, very important, guys. Okay, please remember these levels also. Okay, you'll see questions on that. Okay, clinical questions are based on this. Next thing. After this, lastly, I want you to sum up radial nerve like this. Radial nerve injury. Radial nerve injury, this word R you remember. Radial nerve injury will occur in fracture spiral groove, will occur in Saturday night palsy. Saturday night palsy will occur, will cause wrist drop, will cause what is called another R, spiral groove, Saturday night palsy, wrist drop, and also will be associated with the crutch paralysis. So these are the important clinical terms that you'll get through. A patient having a fracture spiral groove. This probably was the question, or a shaft or spiral groove fracture. Saturday night palsy or honeymoon palsy, two different things. Alcoholic patient, Saturday night palsy. Okay, newly married and sleeping on the partner's arm. That is what the honeymoon palsy. Okay, even honeymoon palsy is radial nerve damage. Wrist drop. Okay, wrist drop, fractured spiral groove. Crutch paralysis, fracture at the, damage or compression at the axilla. Okay, and do remember, spiral groove fractures, spades triceps or spades elbow extension, spades elbow extension. So everything posterior, everything P, the letter P, posterior trochleus nerve, profunda brachii artery, posterior cutaneous nerve of arm, posterior cutaneous nerve of forearm, posterior muscles of the arm, posterior muscles of the forearm, everything posterior in the upper limb is what? Radial nerve.